Good afternoon, everyone, and thanks for joining today's panel discussion on the American Kidney Fund's launch of a roadmap for addressing the unknown causes of kidney disease. My name is Mike Spigler, and I am the Vice President of Patient Services and Kidney Disease Education for the American Kidney Fund. I'll be serving as your moderator this afternoon. Before we get started, I want to take a moment to thank our sponsors who helped make this project possible. And actually, before we do that, just a quick technical overview. Please stay on mute throughout the duration of the webinar. The chat box has been disabled. If you have questions for us as the speakers or the panelists, you can use the Q&A button throughout the time here. We're going to answer questions at the end. We think we'll have plenty of time to do that, but please know that chat has been disabled. So now let me get back to thanking our sponsors. I want to thank first our leadership sponsors, Natera, Otsuka America Pharmaceutical Incorporated, Sanofi Genzyme, and Vertex. And I also want to thank our champion sponsors, Alexion and Travere. We could not have done this project without them, not only from their support as a partner, but also as content experts as well as this program has moved forward. And now to kick off our discussion today, I want to welcome the American Kidney Fund's President and CEO, LaVarn Burton. LaVarn?
Thank you, Mike. This is really an exciting day for us and a truly hopeful moment in the fight against kidney disease as we release the roadmap for addressing the unknown causes of kidney disease and have another opportunity to gather together for your continued input and perspective on this topic. I really want to echo Mike's thanks to our sponsors. Without your support, we would not be able to fulfill our vision for this project. And I want to thank our steering committee, who has been with us every step of the way since the beginning, designing this project, along with the participating individuals and organizations, and our panelists who are with us today. In developing this project, we had one central motivation in mind. Patients understandably want to know what caused their kidney disease or kidney failure. The CDC estimates that 5% of patients with kidney failure do not know the cause. And at AKF, our own data says that for those who are lower socioeconomic status, that even more are likely not to know the cause of their disease and not to have a clear diagnosis. AKF works hard to empower patients and to help them live fuller, healthier lives in the face of kidney disease. To us, it is critically important that anyone with kidney disease have as much information about their health as possible. This information can often inform decision-making around treatments, can indicate whether there may be implications for other family members, for future transplantation, or even for reproductive counseling. So in December of last year, we assembled researchers, organizations, and patients to start to come up with potential solutions. And from that discussion, we developed a consensus document, a roadmap, as we are calling it, for addressing this issue. Today, we are very proud to release the roadmap on AKF's website. And in today's webinar, we will be delving into some of the key issues and themes that have arisen through this project. This roadmap is really just the beginning, and we will be talking about where we see this project going in the future. Thanks again for joining us today, and I will now pass the mic back to Mike.
Thank you, LaVarn. I am happy to say that we have assembled a great panel for you today. First up is Dr. Julie Wright-Nunes. Julie is a practicing nephrologist. She is chair of AKF's Medical Advisory Committee and an associate professor at the University of Michigan. Teresa Calderon is one of AKF's patient ambassadors and a kidney transplant patient living with a rare disease that went undiagnosed for quite some time. Teresa also happens to be a nurse, so she's going to give us perspectives of both sides today. Trudy McKenna is Director of Medical Education at Natera and a genetic counselor with significant experience in the area of rare kidney diseases. And finally, Holly Bodie is the Vice President of Government Affairs for the American Kidney Fund, and she has been working on health policy issues in Washington, D.C. for more than 30 years. I want to thank you all for joining us today on this important topic. And now I'd like to turn it over to Julie to talk about the importance of this topic and the process that AKF took to create the roadmap that was released today. Julie?
Thank you, Mike. Before we jump into the unknown causes of kidney disease roadmap, I wanted to give a brief overview of the American Kidney Fund and why this effort was so important to the work that the American Kidney Fund does. The American Kidney Fund fights kidney disease on all fronts as the nation's leading kidney nonprofit. AKF works on behalf of the 37 million Americans living with kidney disease and millions more at risk, with an unmatched scope of programs that support people wherever they are in their fight against kidney disease, from prevention through post-transplant living. 2021 marks the American Kidney Fund's 50th anniversary, and for 50 years, AKF has put patients first through wide-ranging efforts, all while being consistently rated as one of the most efficient and trusted charities in the United States. The programs allow AKF to fight on all fronts for kidney patients through awareness, advocacy, prevention, public education, professional education, clinical research, and direct financial assistance. The direct financial assistance has given AKF some unique insights into the unknown causes of kidney disease, which I'd like to share with you a little bit more. With 1 in 6 dialysis patients helped each year, and with more than 1,600 of those patients getting a kidney transplant thanks to the American Kidney Fund's assistance, AKF has data on a large segment of patients. These patients are primarily made up of communities of color that would not be able to maintain the cost of their healthcare without AKF. As part of the application process, AKF collects a wealth of data on patients, including information like demographics, treatment types, and comorbidities. The socioeconomic status of these patients is dire. Many are not able to continue working, causing them to lose their savings and income. And complicating matters worse is that as many as up to 1/3 of dialysis patients crash into dialysis, meaning they went into the emergency department not feeling well and being told they have kidney failure and need to start dialysis immediately. The patients we assist have an average annual household income of just over $24,000 and are upside down in expenses versus income. This is important to remember as I show you some data on our population versus the general kidney failure population. This information is from the CDC Data and the United States Renal Data System. Here we see that diabetes and high blood pressure make up about 2/3 of the cases of kidney failure. Glomerulonephritis is listed 3rd, and there are a collection of other causes, including more rare diseases, along with about 5% that are listed here as without a confirmed diagnosis as to what caused their kidney disease and kidney failure. In our unknown chronic kidney disease roadmap, we cite additional studies showing estimates that may even be higher, even up to 15%, leaving many patients who do not know the cause of their kidney disease. Looking at the pool of patients that the American Kidney Fund assists, AKF has about the same percentage of patients with diabetes and high blood pressure as the national pool, but strikingly about 14% of the AKF patients report that they don't know what caused their kidney failure. Although we recognize this is patient-reported data and there may be other causes listed in other sources of data, for example, health records, we felt it was very important to ask, why are these numbers so different from a CDC average? And more importantly, what can we do, along with the rest of the community, to help our patients with this? Next, I'll turn it back over to Mike to talk about the process that the American Kidney Fund went through, along with its partners, to get to this point and the recommendations that we are laying out in our roadmap.
Thank you very much, Julie. I really appreciate it. And let me start by saying right now, you can download the roadmap immediately right now today at kidneyfund.org/UCKD. And it's no charge, and all the information, including what went up to and including at the summit to this report is there as well. I do want to also remind everyone that if you're watching live, I want to thank you for being here and continue to send in your questions using the Q&A box that's on your screen in the Zoom controls. So in light of the prevalence of this problem we were seeing in our grant recipients, AKF sought to join with our partners and sponsors to bring together researchers, patient advocates, advocacy organizations, government agencies, and industry to identify how the kidney community can drive innovation in research, diagnosis, and treatment of the underlying causes of kidney disease. We were able to bring more than 100 of these leaders together virtually on December 1st, 2020, for a collaborative consensus building event called the Unknown Causes of Kidney Disease. The findings of that summit, along with additional background research and interviews, was used to create the roadmap that is being released today. And if you're interested in learning more about the summit and those who participated, a full list can also be found at kidneyfund.org/summit. So you're probably asking what is in the roadmap, and we're going to give you a little bit of an overview of that today. The roadmap released today provides the nation with a consensus document for addressing unknown causes of kidney disease. It has an in-depth discussion as brought forth at the summit of the existing barriers that exist and provides short, mid, and long-term steps for giving patients a better picture of what caused their kidney disease. And again, you can download it for free right now by going to www.kidneyfund.org/UCKD. So now I'm going to ask our speakers to come back online and show their video again. I'm going to open it up for panel discussion as we talk about some of the barriers identified in the roadmap. The first is the problem of kidney patients overall getting a late diagnosis of kidney disease. Second, we identified that the potential of a confirmatory diagnosis may not change treatment, which is unfortunately sometimes the case. But there are other benefits to a confirmatory diagnosis, including implications for family members, implication for future transplantation, and also reproductive counseling. Third is a potential lack of adequate insurance coverage, especially in relation to genetic testing. Fourth is the lack of awareness and perhaps well-established evidence-based information to guide genetic testing, which there are a lot of reasons behind, and that's what we'll get into during our panel discussion. And finally, communication barriers exist between patients and healthcare professionals, both as it relates to health literacy, available time to spend with patients, and cultural competencies. So let's go ahead and talk through this a little bit. I'm going to turn to our panel, and Julie, I'd like to start with you. Why is it that patients are having their kidney disease of any kind really found so late, and what can we all do about it?
Thank you, Mike. I think across the United States, studies have shown that patient awareness about kidneys and then chronic kidney disease is low. And the reasons for this are really multifactorial. Often patients don't feel symptoms until very late in their kidney disease, so may not have a cue for testing or collaborating with providers to get testing. I think studies also show that providers either may not be aware across the spectrum of care of kidney disease or the tools and guidance that they need to communicate a diagnosis and what to do about it is lacking. We need more evidence-based educational trials to help guide across the continuum of care a dialogue about kidneys, kidney disease, kidney risk, and what it means. I think there's also a need for more support across the continuum of kidney disease care, just to make sure that patients are not only informed, but activated in their care. Mm-hmm. And when kidney disease is not identified until later in the disease process, the benefit of therapies might be limited to slow or stop progression. And as I was kind of just skimming through the chat, I already saw a couple of comments about even the utility sometimes of the diagnostic test that we use may not be there as much, and that risk benefit profile changes drastically. So I think that there's a lot of opportunities within and outside of the health system to increase education for patients and providers and the public about the kidneys, kidney health, and kidney disease, and that we have policies that are in place to get patients at risk or with kidney disease the care they need. And I think this roadmap will help us with some of those barriers.
Great. Thank you very much, Julie. Well, patients have been a huge part of this process, both from all the way from the steering committee to the summit itself to reviewing the document and obviously here now today. And we're very, very glad to have Teresa joining us today. So Teresa, before we get kind of into a question, tell us a little bit more about your own personal situation and why did it take so long to get answers in your own case?
For me, and I was a nurse, and so I had knowledge that most people don't. Otherwise, I had been healthy, no health problems. I'd had 4 children with no problems, and all of a sudden, I started slowly having symptoms, but no one could put their finger on what was causing them. My kidney function had declined a little bit, but they were thinking it was caused by something. They just didn't know what. Ultimately, it took about 9 months, and I ended up as one of those patients that shows up at the ER in kidney failure. And that's even, with the knowledge I had. My husband is a nurse also. So when you don't know what is causing things, you can't do anything to make it better or fix it. I ended up having a biopsy and labs beyond labs, and figured out finally after about 9 to 10 months that I had an autoimmune disorder, a vasculitis called Wegener's. So yeah, it's you can't do anything, and you want to know what's going on, but you feel like you're just left hanging, and it's very frustrating. And I knew questions to ask. I knew things to look for, and where to go to look for information, where most people don't have that option. So,
Right, and Teresa, even though you kind of ended up maybe at the same point in your treatment, I mean, do you feel, for people out there that may say, well, what, this person may end up on dialysis anyway or get a transplant anyway, what does it really matter? What did it mean to you, just from a humanistic standpoint, about what caused your kidney failure?
A big thing is just a fear factor. Like, what else is going to happen? If I don't know what caused this, is it going to cause something else? Am I going to, I didn't know. I mean, honestly, I didn't know. Am I going to die? Am I going to, I knew you can treat the kidney failure, but if you don't know what's causing it, you can't stop it. You can't prolong the function of your kidneys. Also, I have 4 children, and is this something I need to be concerned about for them? Is it genetic? Is it something they could possibly end up with later down the road? Because I want to do anything I can to keep my kids from having to go through all of this.
Right.
And just knowing what questions to ask and what I needed to do to take care of myself. You just feel kind of lost.
Yeah. Well, thanks again for sharing your story, both at the summit and also here today as well. And we'll come back to you as well as we
Sure,
go
thank
forward.
you.
Holly, let me turn to you. In your role here at AKF, you have led the fight to get patients better healthcare coverage for kidney patients. Do you think there maybe is some merit to patients with disadvantaged socioeconomic status having a harder time getting an accurate diagnosis? And what role does their healthcare coverage play in that?
Yes, Mike, absolutely no question that there are people's socioeconomic status is directly related to health coverage, and health coverage is directly related to getting an accurate diagnosis and treatment. Many disadvantaged communities, they may have very intermittent access to healthcare and healthcare coverage. They may have access to plans that don't cover very much. They have very, very high deductibles. And they may, not have access through their plan to, to comprehensive care. And so I think having ongoing, affordable, and comprehensive healthcare is really important for all communities, but especially those who have not always been able to get the health insurance that they need. And so I think ensuring that people have health insurance coverage is a very basic step in making sure that people get an accurate diagnosis and the treatment. There are many other things that have a role as well. Providers having cultural competencies, a lack of providers in certain underserved, often low-income areas. And sometimes, I think we have seen this play out with vaccines. Can be a distrust of our healthcare system. So there are a multiplicity of problems that need to be addressed.
Thank you very much. Well, Trudy, we're very glad to have you here as not only your experience with Natera, but also as a genetic counselor, which is a key part of this whole process, and with physicians working with their patients. What are some of the most common questions you get from healthcare professionals that you've consulted with, and how do we bridge the gap in the understanding of genetic testing and its implications for patients.
Yeah, I think, I think some of our panelists have already hit on some of the main themes that we keep hearing. I think if we broke down the common questions that we hear from providers, I kind of put them into two buckets. One is the logistical bucket, which is, the concern about cost of the patient, billing, insurance coverage, and then also resources in that whole logistical approach. I don't, so provider, I'm not that familiar with genetics. It's been a long time since I was in med school, but I don't deal with genetics that often. What if I have questions? What are the resources that are available to me, and not, months down the road, but what can I actually do, pre-test to determine who should I test after I get the test results? What's available for my patients? And then I think the second bucket is kind of building on those logistical questions are the clinical questions. Who should I start testing? I think this was a great topic to say unknown kidney disease with, some of the studies we've seen in the yield of genetic diagnoses in this population is a great place to start to say, if a patient who doesn't have an etiology for their kidney disease, have you thought about genetic testing? And really starting to incorporate that into just the mindset of that initial, workup is really including that in that. But then you also have to provide all that additional support. What kind of tests do I do? There's a lot of different panels, single gene tests, large gene tests, and it can get the terminology also can be very foreign. So really being able to help a provider, really think about what kind of testing is really appropriate. And then, what do I do with those results when they come back? What does a negative test result mean? Am I providing the right information to the patient? Do I feel comfortable with that? So I think just to kind of support what's already been said, there's a lot of education, there's a lot of answers we already have, and there's a lot that we can really continue, I think, in roadmaps like this to start building those bridges.
Great. Thank you very much. Julie, I have one more question for you before we turn back over to some of the solutions. But what advice do you have for other physicians who may be watching today and wondering if one of their patients may have an undiagnosed rare disease? How would you start that conversation with the patient, and what are the first steps that they should be taking?
Thank you, Mike. And I even saw when I was peeking through the chat, some questions already right on that topic. So maybe that will help, or either now or at the end. But I think, I'm hopeful that this topic in general is something that we can get more clarity on as far as the next steps. As a practicing nephrologist, I like to work on solutions with my patients, but I also acknowledge that we have gaps that we need to address. And so I think that's exactly kind of the question that you're asking. As a few suggestions, I think that at times we may see that our patients have a strong family history of having kidney disease or kidney failure. So that may be a point at which we hone in more on a potential for whether other testing like genetics might be useful. As Trudy explained, we still have a ways to go with maybe interpretation, preparing with a genetics person to help people with results that may still be fuzzy, quite frankly, and how to get those tests done, which I think, again, the roadmap is trying to target in partnership with others. I think referring to a nephrologic specialist might be in order to investigate kidney disease if there is a strong family history, people are at advanced stages, or if traditional risk factors like high blood pressure, diabetes aren't present, or if they're present at a young age, or if there's concerning features that can't be attributed to what commonly doctors or providers might see in patients related to a kidney problem. I think, honestly, the most important aspect is starting a conversation in the first place about kidneys and kidney disease. And that might seem intuitive and not very helpful. But the studies that I and others have done have shown that up to 80% of people with evidence of advanced kidney disease in the United States do not even understand they have a kidney problem. And as you know, Mike, research that we've done with the support of the AKF shows even in a kidney practice with established nephrologists, 30% of people are saying they don't have a kidney problem or kidney disease. So I think starting a dialogue, first of all, is important if we see abnormalities in kidney function or urine testing, and then helping patients negotiate through what that means and being transparent. If at times there's things we do not yet know or are not sure about, explaining this and then strategizing with the patient on how we're going to partner together to figure out in the next steps.
I think all that is spot on. And, I think you've probably heard me say this a million times in meetings we've had, but, I had that exact same experience. I'm the primary caregiver for my mom. I took her to a primary care appointment and her doctor was going through the results and just got to her creatinine and just said, well, her kidney function's a little off, nothing to worry about. And it was just going to push right on through. And luckily, in the position I'm in, I could stop and ask that question to learn more about what he was seeing. And she was on drugs that were, medications that were damaging her kidneys even further. And, with that conversation going and an understanding of it, we've been able to keep her at stage 3B now for several years. But that is definitely a challenge that we definitely see. To your point, and I do see some questions coming in, and everyone, please, that's watching, feel free to continue to send in your questions. Julie, this is probably a question for you, and maybe Trudy can jump in on it as well, but just I'm seeing regarding, this being such a difficult thing to diagnose, and sometimes and even a kidney biopsy does not help. What role does a biopsy play in this? And, how often do you use a biopsy? What situations do you usually use that?
Yes, I can start with that. I think that's a great question. And I would also say that for anybody who might do kidney biopsies or order them, like myself, I don't know that we in the kidney community have straightforward answers or established algorithms that fit every person, right? And I think that's what makes it challenging. I think most of us will try to get some pathologic diagnosis, anatomic pathology that we can look at. But here's where the struggle lies. And particularly as people get more advanced in their disease, the risk benefit profile of getting, let's say, for example, specifically a kidney biopsy is going to change to the point of kidneys look small and shrunken. And again, people are at the point where, we have heard, unfortunately, where they're either crashing into dialysis, and we think that there's so much risk and not much benefit in getting tissue, then unfortunately, we may not be in a position where we would order such a test. And that's where I think there could be, maybe not yet, but in the future and in this roadmap, kind of more help that we can get related to either genetics to give people answers. And we can debate a little bit about whether or not prognostically that will always help, or even if it's going to change management. But I do think there's also a role for patients knowing, right? And so that's the opportunity that I think this roadmap's really going to help with, including some of the researchers in the kidney arena that are publishing articles, for example, just recently in Kidney International about the benefit of looking at the entire genome in kidney disease. We still haven't defined all of that yet, but I think that that's really where this roadmap, working with folks like that, will help.
Great. I'm also I see Alicia Lawrence from NORD joining as well. Thank you for being here. And she has a question, or not a question, but more of a comment, probably along the lines, maybe for you, Holly, just regarding not just insurance issues, but another major issue are families living in remote areas where they don't have great access to care. They're not going to go to a University of Michigan or a teaching hospital. Is that something that you're seeing in the work we're doing in government affairs as well?
Yes, absolutely. Underserved communities, which can be a remote rural community, and it can even be sometimes in urban centers, people don't always have, because they don't have the health insurance, they may not have access to treatment. And so absolutely, we have seen this happen. We know that patients don't always have access to the providers and the treatment that they need to get. So that's something we'll certainly be examining more in depth when we move forward with our roadmap. Great.
All right, well, without further ado, let's talk about some ideas that the summit and this roadmap is suggesting for how to tackle this problem. So there are really kind of 4 overarching areas that the roadmap lays out. Obviously, it goes much more in depth in that, but here are the kind of the broad areas. One is advocating for widespread and equitable insurance coverage of tests to help understand and diagnose kidney disease, including current and future tests related to genetics. Increasing providers' interest and awareness about the range of possible root causes of kidney disease through education and incentive structures. Educating patients about kidney disease and testing in an effective, culturally competent way, and empowering them to advocate for an accurate diagnosis. And finally, based on evidence available, encouraging the development of national standards related to when and how genetic testing can be useful and applied. So let's do another round of questions. Trudy, I'm going to start with you this time. What is your reaction to the finding that national standards and guidelines are needed to help solve this problem of patients whose CKD is unknown cause?
Yeah, I think that's a great finding and really exciting and encouraging. We really want to start developing the evidence-based medicine with that end goal of establishing guidelines, and this can really help drive that sharing of data, sharing of outcomes, creating that evidence-based medicine, and then sharing that and educating both patients and providers with that goal of addressing some of those questions we've already discussed that both patients and providers have. Who do I test? How do I test? When do I test? And with also the underlying goal of, with reimbursement, eliminating some of those health inequities. So I think that's a great plan.
Great. Teresa, I'm going to come back to you. As we've mentioned, you kind of have the special situation of being on both sides of the hospital bed, as it were, both as a nurse and a patient. What are your thoughts on the need for patients to become more empowered about their health, and what recommendations do you have for professionals who want to foster those interactions?
Definitely, one of the biggest jobs as a nurse is to be an advocate for your patient. So that's a huge word. And then I learned that you have to be an advocate for yourself as well. I think many patients are afraid to ask questions. They don't even know what questions to ask if they aren't. I think sometimes as caregivers, we make assumptions that a patient knows things, or, I think it's really important on our end, on the caregiver end of it, to let them know it's okay to ask questions, make sure they understand what we're saying to them. And just, I actually didn't want to ask. I thought they're going to think I'm crazy because I keep coming back to the doctor saying this is what's going on. And I was actually initially diagnosed with anxiety. And was told that I was a nurse and you see all these people with all these things, and this is you're just thinking you have all these problems, and you don't. So I think we have to be more open-minded and understand that people know their bodies, and listen. We have to be active listeners and encourage patients to advocate for themselves and listen to them when they do tell us things.
A follow-up question, Teresa, I'm thinking, especially being a nurse too. I mean, I know I think probably even myself, if I'm going to be honest with everyone, has been guilty of this, is kind of looking things up online, right, and going to Dr. Google. Is that something you were doing as part of that process? And did you have anxiety about bringing kind of what you found to your doctor and asking those questions?
I did. I definitely went to the internet. I tried to make sure I was using reputable sources. I went to some websites like Johns Hopkins. There were some other places, and I found some that maybe weren't so reputable, but it still put thoughts in my head. And then, to tell my doctor, well, online I saw, and they're like, come on, you've been online, you know better. But I think that's another good option for patients if we give them good sites to go to. Don't just say, well, look it up online. Give them the research hospitals. There's a ton of information out there that's correct and accurate. It's just knowing which ones to go to. But yeah, I was guilty of that too.
Right. Thanks, Teresa. All right, Julie, I'm going to come back to you. So as a practicing nephrologist, what are some of the challenges that providers may face either when they see a patient with advanced CKD or any CKD with an unclear cause?
Great, thank you, Mike. And I think that kind of goes along, at least with the first couple of comments, that one of our participants here has really hit the nail on the head. And I'll get to that in a second. But I think there's several challenges. As a practicing nephrologist and a doctor, I always try to focus on two main tenets of caring for people. One, helping my patients achieve healing and recognizing that's not always a cure. And that's hard for me to say out loud, but that's true. And then doing no harm. And so when we get into advanced kidney disease, as I mentioned, the risk-benefit profiles, even of standard tests that might be things that we'd usually do, change, as well as potential therapies that may not even be of benefit if people are very advanced in their kidney disease. I think there's issues that many studies don't include patients with kidney disease, even looking myself for, dosing of some of the newer medications that are coming up, and I'll look and see if, gosh, what do they say for the CKD 4 or 5, the advanced stage, and oh, no trials really included these folks. I mean, that's a problem. It's been noted in the literature. We need to fix it. It won't be a quick fix, but at least we can start with advocacy. And then I think weighing the risks versus the benefits of any therapy is always going to be critical, and being transparent about it. It's very difficult for me to have a conversation sometimes, not so much about what I do know and what I can do for patients, but even more so when maybe there isn't data, or maybe I'm not quite sure what's going on. And I think it's helped me to know that if we don't have science there quite yet, then I share that, but I use the information that I have in talking with the patients so we can kind of face the next steps together. And I think that that helps. I know that's not a really great answer that people might want coming to this, but that's why we're having a roadmap and where we need people's input as to what we need to include in that, right? So that we can tackle these things head on.
Absolutely. And, you know, again, these are kind of overarching pieces. I would say, again, I encourage everyone to download the roadmap and read it. It is kidneyfund.org/UCKD. And again, there's a lot more in depth on these areas in the roadmap. But talking about advocacy and what to do next, Holly, a final question for you in this section. What advice do you have for the healthcare professionals listening today who want to make a difference and advocate for their patients? Are there steps they can take to help AKF fight for change in this area?
Yeah, absolutely. I think it can seem daunting for many, many people to feel that they are able to have a voice with their elected officials, and this can be at the state and the federal level. And I think what it takes to have an impact is knowing the right ways to communicate. And by that, I mostly mean at this point, social media is a very effective way. You can follow your members of Congress, your senators, your local and state officials on Twitter. They definitely pay attention to what people are tweeting about. So that is one really effective way to communicate. I think also consistency and persistence are really important. I've been a lobbyist for a long time, but I also did work on Capitol Hill. And people are able, if they're consistent and they're persistent and polite, you're often able to break through and actually start creating some relationships with congressional staff or a member's office. It doesn't happen overnight, but if it's something you're really dedicated to, I've certainly seen it with many of our advocates here at AKF. They talk to their members' staff a lot. They come to town for fly-ins, et cetera, and they have built strong, lasting relationships with congressional offices. Some of it has to do with luck. Maybe you're lucky and your member of Congress really cares about healthcare or is in all the right committees. That can help too, but any member of Congress is going to be interested in hearing from a constituent. Other things you can do, most members have town hall meetings. They're virtual right now. They may have Twitter conversations. Those are great things to do. And then I know many of you probably belong to professional organizations, and most organizations have fly-ins, obviously virtual at the moment, but in person usually. And those are great ways to be part of a group and to get to know staff and to get to see what lobbying is like up close and personal before you maybe do it on your own. So those are just some. And then if you want to become an ambassador for the American Kidney Fund, that's what we call our advocates, just go to our website and there's a button at the top of the page that says advocacy, and you can join our advocacy network, and we would love to have you. Thanks.
Great. Thanks, Holly. And I see a very great question that's come in. I'll save it to the Q&A session, but that's a good prompt for me to remind everyone again, if you are watching live, please join our conversation. Let us know you're here. Type in your feedback or input for us to consider, or questions about the roadmap, and we'll try to get as many questions as we can at the end here. But before we do that, let's talk about next steps. I mean, a lot of times white papers are put out and nothing really happens. I want to assure everyone today that that is not the case with this project, and AKF is committed to seeing these changes through. In fact, we've already assembled 3 implementation groups made up of patient advocates, rare disease organizations, kidney advocacy organizations, and leading medical professionals to address this and continue the project. Each group is going to focus on a particular area, one on public policy, one on patient and caregiver empowerment, and one on healthcare professional awareness and education. The public policy group will really be focusing on ensuring that equitable insurance coverage that we've talked about for patients that are seeking an accurate diagnosis. The patient and caregiver group is going to be focused on creating tools to empower patients to work effectively with the providers, and the healthcare professional awareness and education group. We're working to address some knowledge gaps that have been identified through the summit and other methods. So having said that, we are now ready to take your questions. One more time, if you're watching live, you can use the Q&A feature on the toolbar to send us your questions. Julie, I think this is probably best suited for you. It's actually directed to you from one of our physicians that are watching today. When lab results reveal a kidney issue that still needs to be diagnosed, is there any evidence to show that an ACE inhibitor, and I guess you could say really any other kind of preventative steps, should be prescribed as a preventative measure until they have more information?
Yes, great question. So I would say when there's indications, for example, like diabetes or protein in the urine, we do have really good evidence for that. So those would be cases where I think things would be straightforward. It wouldn't be bad otherwise to start it, but for prevention, not to my knowledge, as far as preemptively starting, although they are excellent medications and we all know what the potential risk could be. So we want to avoid them, obviously, in people who were women of childbearing age and perhaps pregnant, and then certainly can be associated with allergic reactions, angioedema, and so forth. So again, everything has risks and benefits, but overall for diabetic, for people with diabetes or protein in the urine, those would be clearer indications.
Great, thank you. A question, so we did have some questions coming in advance as well. This one, I think maybe Holly and Trudy, I'd love to give both of your kind of thoughts on this, but the first one, are there risks to patients who get a genetic test in terms of life insurance, disability insurance, et cetera? Holly, why don't I start with you and then we'll go to Trudy.
Well, the answer to that question is yes. There definitely are risks. In getting a new life insurance policy, insurers can use your genetic information in determining your premium. And the last time that Congress passed a law on this was 2008. The legislation called Genetic Information Non-Discrimination Act, or GINA as it's more commonly known. And in 13 years, especially the past 13 years, a lot of things have changed. And there's probably, I know there's a need for that legislation to be updated. So yeah, there definitely are some risks for patients.
Thanks. Trudy, how often do you see this, and what do you tell providers or patients that have this kind of question?
We definitely see that question a lot. I think in most cases, the largest risk is for the asymptomatic patient where they don't have a diagnosis and they may be given a diagnosis before they develop symptoms if they don't have their life insurance and long-term healthcare insurance in place. So that is a discussion that a lot of genetic counselors will have with patients, not just with kidney disease genetic testing, but any kind of genetic testing. But there are, as Holly mentioned, some provisions in place with the GINA Act to not discriminate with health insurance and employment. So we do kind of walk through patients through that just to ask those questions. If you already have a diagnosis, these may not change your insurance eligibility, because if you have autosomal dominant polycystic kidney disease and you just find the genetic mutation, that's not changing really anything that an insurance provider is likely looking at. So it's probably not a real risk for a lot of patients, but it's a really good question to ask and to make sure that you feel comfortable proceeding with doing testing before you do that.
Great, thank you, Trudy. Julie, question for you. What would be a typical starting point for kidney issues? So for the primary care physicians here or other specialists that are non-nephrology, when's the right time to involve a kidney doctor to assist with this?
Sure. So there are guidelines related to testing to some extent in certain conditions like diabetes as a starting point, or hypertension just for blood testing and urine testing. There's also even some guidance that's provided, for example, with national kidney organizations about a GFR cutoff for patients of less than 30. But otherwise, I'm not really sure that there have to be typical starting points. I think, as providers, if we get blood tests to determine if the kidney function is abnormal, or urine testing is looking like there's blood or protein microscopically, and that's confirmed, because sometimes there's transient issues, I'd say that this certainly could prompt an evaluation and some input from nephrologic colleagues. I think other things that might prompt would be symptoms that maybe people are getting without the tests, that are things like leg swelling or high blood pressure in a young person, and significant macroscopic changes in the urine that continue. So perhaps gross hematuria or blood. I would also say if there's any concerns by providers across the continuum of care, that a patient might not have or present the typical risk factors of kidney disease, either in blood or urine testing, and it remains consistently abnormal, I think having our radar up to refer at that point is a good idea as well.
Great. Teresa, a question for you, and I think Julia alluded to this in one of her comments earlier, just that there certainly is debate on the ultimate endpoint for patients, and when does it make sense to really focus on this diagnostic piece. Maybe kind of I could give kind of a counterpoint here, but Teresa, for you, as a patient and going through this, I mean, talk about what it meant to you to finally have an answer for this, and do you feel like it's important for patients to get a diagnosis, even if it meant nothing would have changed in your care?
I think it's very important, just peace of mind. I think we all want to know. I mean, all of us want to know when something happens. Our first question is, how did that happen? Or why did that happen? And just an understanding of, it's your body, an understanding of what's going on, even if it doesn't change your treatment, it doesn't change what you're going to do. It's not going to change the outcome. But just for, especially anybody dealing with a chronic disease, mentally, mental health is a big part of it as well. There's so many emotions. There's a lot of people end up with depression from it, things like that. I think all of that can be helped when you know and understand how you got there and why you got there. Did I do something to cause this, or where did this come from? It's more of a peace of mind. Someone that doesn't have a whole lot of medical knowledge might not totally understand what it is, but to know that, to have confidence in your doctors, you're going to have a lot more confidence in your caregivers when they can say, this is what happened, this is how we got here, other than them saying, I don't know, this is where we are and we're going to deal with it, but I can't tell you how we got here. It doesn't mean that they're not trying, but from someone who's already nervous about, doctors and healthcare and going to the hospital, and then when they're told, well, we don't really know what's going on, that makes it, they're not going to ask as many questions. I just think it just helps in your peace of mind. And people, their friends are going to ask them, how did this happen? How did you get to this point? And to be able to give answers rather than just say, I don't know. I just think it helps you with direction and where you're going, and gives you the confidence to take care of yourself and confidence in your caregivers.
Sure. And Julie, knowing there's not like a right or wrong side of this, and not to put you to counterpoint that in tough position, but just think, there's risk, with these two. There's cost involved with the test, right? There is potentially some slight or not slight risk with some of the secondary testing as well. How do you balance that out in looking at a patient's risk profile to determine what to do?
Thanks, Mike. I think it depends on the type of workup we're suggesting. So if something isn't very invasive or somewhat invasive, for example, a kidney biopsy, right? And I talked about how an advanced disease, maybe we would think, although I think many of us would try, maybe we think there'd just be too many risks and we would not have anything prognostically or to inform therapy. So in that case, we might be saying, well, gosh, that's not something we'd pursue. But I would actually say that I'm really not on the flip side of our patient advocates. I'd say I'm on their side. And I think that testing, whenever we can do it, if we're unsure, can help for implications for the future, potentially for offspring, for potentially implications for transplantation and just the risks after transplant. And I really think the peace of mind is huge, and we're developing evidence related to it. And I feel like I keep saying this repeatedly, but I feel like this is such an important and still understudied area clinically, just showing that patients really want information early and don't feel that they get this information soon enough just to know that there's a problem. So to continue advocating for patients to be informed so that they can be actively engaged. And even if, for example, they are at an advanced stage where there are more limited therapeutic options, I feel like patients are very much wanting to get activated and on board with things they can do to slow progression, even if it's already been identified. So again, I don't know if that's really a counterpoint. It's maybe an agreement point.
That's fine. That's fine too. We'll take that also. Thank you, Julie. You mentioned transplant.
Mike, I'd love to just,
Yeah, please do.
sorry, I was just going to say, I would just love to add another agreement with Julie and Teresa's comment, just coming from the genetics perspective, where, you know, a lot of times with genetic disease, I remember counseling patients and saying, you know, something is not that rare when it was 1 in 30,000, because comparatively, you know, you're dealing with so many rare conditions, and the benefit of having a diagnosis, and sometimes it's undiagnosed because it's so rare, and
Right.
finding those communities, you know, especially with the internet and, you know, just seeing that evolve over years has been such a benefit to families to find that home base. So they're not the only person. You know, if you live in a town with 30,000 people, you're that one person. It can feel very isolating. And to have that diagnosis and to be able to reach out, I think has been really life-changing for a lot of families.
Absolutely. And, you know, the other piece of this too, I mean, finding patients and building that community drives innovation and treatments too, right? So, I mean, that's a huge part of it, is if we can find these patients, hopefully we can start to actually develop some things to actually help them. Tree, we had a question that came in prior regarding transplantation, and Julie had mentioned that. And I know this is probably the last question we have time for, but what are the areas where genetic follow-up might be helpful in transplant evaluations, and is there more work needed in some areas?
Yeah, I think to Julie's earlier point, there's always more work needed, but, you know, we've identified a lot of areas. You know, we also mentioned biopsies. So we've had a lot of interest in genetic testing from transplant centers where biopsies were inconclusive because of the health of the kidneys by the time they got there. So that's been one place where genetic testing has been really helpful. Donor assessment. So we have a family history, you know, and KDIGO even has recommendations about this. If there's a family history of genetic disease or there's unknown etiology, if you're looking at a living related donor, it's really important to do as much as you can to make sure that you've identified a potential genetic cause for those conditions. And so there's definitely, you know, and KDIGO also has some other recommendations about certain diseases where there should be, you know, genetic testing performed as well. And I think that that's where we can, you know, continue to develop what is appropriate testing for donors. I don't think it's right now we want to test donors for everything prior to transplant, but there's definitely situations where that can help both donor and recipient outcomes.
Perfect. Well, great questions, everyone. Great answers to the panel. I want to thank you for joining us, participating today. But before we leave, I want to give each of you just a chance to give your final thoughts. And Holly, I'm going to put you on the spot first. Any final thoughts that you want to leave everyone with?
Just want to say that we as an organization, American Kidney Fund, we're really excited to be working on this project. And for me personally, on the public policy side, there's clearly a lot of work that needs to be done for these patients and to making sure that people have access to the tests and the treatment that they need. And so we look forward to working on this in the future.
Great. Thank you, Holly. Teresa, how about you?
First, thank you for giving me a chance to share my story and the patient point of view. And I go back to the knowledge, the last question you asked me about the importance of understanding what caused your kidney failure. For me, one of my biggest fears was after I got my transplant, am I going to lose this kidney to the same issue?
Right.
So yeah, that's another thing I think that's so important. Knowing, you know, going forward, if you're going to get a kidney transplant, how do we take care of that kidney so that we don't end up in the same boat if we can avoid that? So just that's another reason I think it's so important to understand what got us to that point in the first place, so we can not go there again once we get that transplant.
That's a really great point, Teresa. And you know, we actually had a patient, as you know, at the summit who was told she had high blood pressure as the cause of her kidney failure. Got a living donor transplant and then lost that transplant to a rare disease. And, you know, kidney transplants are so precious. Anything we can do to preserve those and not lose them is a critically important goal of this as well. Really good point. Trudy, how about you?
Well, I just want to first thank AKF for first inviting me to this panel and also to participate in the summit, but overarchingly just to tackle this this idea of unknown causes of kidney disease and recognizing the importance of genetics. I mean, I'm always going to go back to, you know, I'm a genetics nerd, so I really think that, you know, when I first started in genetics, it was a really separate entity from a lot of other subspecialties, and it's been really exciting to see how it really is going to be integrated into routine care for all medicine. And this is a great step in starting to really get that integration moving forward. So I think it's going to be a really exciting next couple of years while we do that.
Thanks, Trudy. And Julie, I'm going to leave the final thought to you.
Thank you, Mike, and everybody. I just want to say I appreciate the time and effort of everybody participating in this meeting. Great comments. And I think everybody here is really the foundation that's going to help us achieve goals set forth in our roadmap and work with patients and policymakers and providers and everybody else to ensure that patients are not only informed, but activated in their care. So really on behalf of the American Kidney Fund and the stellar team that you, Mike, and Lavarne and everybody assembled, just a big thank you to everyone.
Great. Well, I want to give again a huge thanks to all of our panelists, and for all of you who joined us today. I want to give special thanks again to our sponsors: Natera, Otsuka America Pharmaceutical, Sanofi Genzyme, Vertex, Alexion, and Travere. And there's so much more to come on this unknown causes of kidney disease project. Again, in the meantime, the roadmap can be downloaded at kidneyfund.org/UCKD. I hope to see you there at the link and downloading it soon. And until then, have a great afternoon, everyone, and thanks again for coming.
Thanks, everyone. Bye.